on the subject that continues to shape the future of women's health. Dr. K Jayakrishnan will be talking on the topic endometriosis management, surgery or IVF, choosing the optimal path. May I please invite Dr. Jayakrishnan? He is the Chief Consultant and Chairman of KJK Hospital, Trivandrum. He has more than 40 years of experience in reproductive medicine, and he's been the organizing chairperson for Advances for the past 25 years. He has more than 38 publications in national and 14 publications in international journals. Over to you, sir.
Good afternoon to all. The question is whether you do laparoscopy or you send a patient for IVF, not based on an endoscopic surgeon or a ART specialist, but for a common gynecologist. How do you manage grade 3 and grade 4 endometriosis? What are the options and what are the right pathway? So we all know it's a complex systemic clinical syndrome that can affect the impact and negatively the woman's reproductive health and quality of life. You find there is a chronic inflammation and hormonal dependence, which are the main underlying pathophysiological mechanisms that drive endometriosis. When you look at the incidence, you find that it is around 10% of the reproductive age suffer from endometriosis, and 1/3 of them experience infertility. And when you look at the infertile section of the people, you find 50% of women, most probably in the Kerala setup, we find 30 to 40% are found to be suffering from endometriosis. Endometriosis affects the whole peritoneal cavity, the uterus, the tubes, and the ovary. And you find there is a disordered follicular genesis and ovulation. And you find endometriosis per se, the patient has got a reduced oocyte quality. When you look at the endometrial receptivity, you find the receptivity is decreased. And when you look at the tubes and the ovaries, sometimes in moderate to severe degree, you find that the tubes and the ovaries are anatomically disturbed, interfering with the fertilization. They are not blocked, but anatomically they are adherent and forms pseudohydrosalpinx. But the fimbria is very well not affected in this group. And you find mild or minimal endometriosis, there is a peritoneal environment is changed. You have a lot of interleukins and chemotaxins which interfere with the fertility. So endometriosis affects infertility. It could be a mechanical problem in the tubes and ovaries. It could be inflammatory, hormonal, genetic and environmental factors. And it is known to contribute infertility with anatomical distortion of the and pelvic adhesions of the tube as well as the ovary, as in moderate or severe degree. When you look at a large data of more than 27,294 ART cycles, 16 years of review, which suggested that endometriosis patients have lower oocyte numbers. But you find that fertility, you find the fertilization and the pregnancy rate are as similar as in a non-endometriotic women. We start with a simple procedure like intrauterine insemination. Which are the group of patients which you can go for intrauterine insemination? It is a minimal and mild endometriosis per se, which are the ideal patients to go for intrauterine insemination. We commonly go for a laparoscopic procedure, especially when the woman doesn't conceive after 2 years, 3 years, to find out whether the tubes are normal, whether the peritoneal environment is normal, and we find mild or minimal endometriosis, we coagulate, and we find most of them do conceive within a period of 1 year. So what do you do when this group of patients who do not conceive within a period of 1 year, they are subjected to procedure known as intrauterine insemination with ovarian stimulation, which could be either oral ovulogents or with gonadotropins. So mild and minimal endometriosis are the ideal group of patients which you can go for IUI, and you find good success in this group of patients. Do you have to manage endometriosis prior to ART? Suppose you have taken the patient for IVF, do you have to manage these patients before ART? GnRH analogs were given prior to ART with the idea that endometriosis produces inflammation, and if you can give GnRH analog for 3 months, 6 months, according to Salam et al., it reduces the inflammatory action, and you find a better response when you take these patients for IVF. But the Cochrane review, 8 RCTs, 640 participants, and any stage of endometriosis conclude that long-term GnRH therapy, maybe 3 months or 6 months therapy, has got uncertain effects, means that it may not be beneficial on the clinical pregnancy, miscarriage, live birth rate when compared to no pre-treatment alone. So earlier we used to give 3 months, 6 months, but the recent reviews tells that it's not much benefit of giving them for 3 months or 6 months. What about a patient coming with ovarian endometrioma? Ovarian endometrioma persists in about 50% of the causes of the cases, and you find that endometriosis per se destroys the follicles. When you look at the histological studies reporting the invasion of the cortex, which produces fibrosis and fibrosis in the vascular networks. So you have to be clear that endometriosis per se reduces the AMH. So it is mandatory that any patient coming with endometrioma, you have to look at the reserve. So that is why we look at the AMH, and you find most of the patients, the AMH is low. Then only you decide whether you can go for a surgery or non-surgery. Suppose you do a surgical excision, you find there's a further decline in the ovarian reserve up to 38 to 40%. So ovarian decline is not alone surgical excision, but the disease process itself by fibrosis and irregular vascular networks reduces the AMH profile. And the effect of surgery on the ovarian decline is greater when you have a bilateral endometriotic cyst and when repeated surgeries have been done. It is said the best surgery is the first surgery, and after the first surgery, when the patient comes with recurrence, you have to think twice before doing an operative laparoscopy. So the recommendations are, there is insufficient evidence to recommend use of GnRH agonists. Don't have to give monthly injections of depot preparations or hormonal contraceptives or progestogens to improve the live births. And suppressive hormonal therapies can be considered after endometriosis. You find it is moderate, severe, whether you can give hormonal therapies, but the patient is associated with symptoms or the disease recurrence, they are waiting for ART, you can give hormonal therapies at the time period you are waiting for that. So there is also insufficient evidence to recommend aromatase inhibitors as pre-treatment prior to ART. So this is the recommendation of the most of the guidelines in endometriosis. This is an interesting study by Casals in 2021 comparing the reproductive outcome in women with infertility and deep infiltrating endometriosis who received IVF with and without surgery. This group of patients underwent surgery and went for IVF. Another group went directly for IVF. And it was according to this group, they found that endometriosis who received IVF with or without previous surgery have a live birth rate 2.5 times higher in the operated group versus in the non-operated group. So the operated group, when they went for IVF, had a higher live birth rate. Also, data from the incomplete surgery groups also told that even if they underwent an incomplete surgery also, a higher pregnancy rate per patient for surgery before IVF, the odds ratio being 1.63. So surgery has got some benefit, but you can decide whether you have to go for a surgery or not go for a surgery. And this already has been told, long-term agonist therapy is no longer being given because of the uncertain effects of GnRH analogs on ART outcomes. And what are the effects of endometrioma? Suppose you have a patient coming with endometrioma and you're going to subject them for ovarian stimulation. First thing you have to keep in mind that ovarian endometrioma is a space-occupying lesion occupying the cortex, and you find there is a lower number of follicles and oocytes. That is why mandatory you look at the AMH even if you're going for ovulation induction. And when you compare to the healthy ovary, you find that the number of follicles and oocytes are much less in the area where you have the endometrioma. And it is said that endometriomas between 10 to 50 mm, that is 1 centimeter to 5 centimeter, going for IVF, have higher doses of gonadotrophins and fewer oocytes retrieved. But most important thing, in spite of oocytes being less, the oocyte maturation is not affected. So this is the thing you have to keep in mind. What are the outcomes after IVF in patients with endometrioma? Even though they have got endometriosis, the dosage of gonadotrophins may be high. The total number of embryos could be high quality embryos. The clinical pregnancy and live birth rate are similar to women with and without ovarian endometrioma. That is, with endometrioma, without endometrioma, you find the clinical pregnancy and live birth rate are similar. And it has been reported that endometrioma more than 30 millimeters has got a negative effect on the total number of follicles and oocytes retrieved. And this also you have to keep in mind. And any endometrioma more than 3 to 4 centimeters, you find that is an indication to go for a surgical outcome. So I will just go through IVF because of for a few slides. What are the downregulation protocols you do for the ovarian stimulation? You can have GnRH agonist, which was used all along, and you have the antagonists coming in the past 2 decades. And several clinical outcomes are evaluated GnRH agonist versus GnRH antagonist protocols in patients undergoing endometriosis during assisted reproductive techniques. And you find that there is no difference between agonist and antagonist. But one thing is sure, the decreased ovarian reserve after endometriotic cystectomy, no difference. Even though the number of oocytes was less, there was no difference in the implantation, clinical pregnancy, even though prolonged protocols leads to improved clinical outcomes. So you can use either agonist protocol or antagonist protocol, but you find that the pregnancy rates are not much affected. The oocyte number alone is being affected. So this already has been told regarding the long protocols over there. So the recommendations are GnRH agonist as well as antagonist when you are taking the patient for IVF can be offered because no difference has been demonstrated in the clinical pregnancy and live birth rate. And when you come to the ovarian stimulation protocols, you find there is no superiority. You can use the follicle stimulating hormone or you can use the highly purified HMG. The X-ray tells you you can use both. There is no specific protocol for FSH or HMG alone. And patients with endometriosis undergoing ovarian stimulation, only thing you have to keep in mind, may have a reduced ovarian response. So you may have to start with 300 units of gonadotrophins in this group when compared to 200 or 225. So the recommendations according to the various guidelines are, no particular gonadotrophin is recommended. You can use recombinant as well as urinary. Higher dosage may be required in stage 3, stage 4. And there is insufficient data. Some people have got a habit of adding letrozole, clomiphene citrate to gonadotrophins. Insufficient data to use letrozole as an adjuvant to gonadotrophins in women with endometriosis. So whether you give prophylactic antibiotics at the time of oocyte retrieval in this group of patients with endometriosis when you go for IVF, insufficient evidence to recommend routine use of prophylactic antibiotics. But when you do a transvaginal oocyte retrieval, you happen to puncture the endometrioma, it should be considered. So no evidence to recommend any particular technique of vaginal lavage before performing transvaginal. But we usually, when you puncture it, we give them prophylactic antibiotics and give 3 doses and then step on to the oral medications. If you find endometrioma at the time of oocyte retrieval, whether you would go for a transvaginal whether you'd like to aspirate the endometrium at the same time, it is not recommended to aspirate the endometrium at the same time of transvaginal oocyte retrieval unless you find that the endometrium is inhibiting your approach to the follicle. So for easy accessibility, you may have sometimes to puncture the ovarian endometrioma, but puncture, if you have done a puncture, definitely an extended course of antibiotics is given. And when you send the patient back home, she should be counseled the need to report, especially when she has pain or fever or any of these things. The chances of peritonitis can be kept in mind. So patients with endometriosis and non-male factor, you can go for IVF. That doesn't mean all patients you have to go for an ICSI procedure. So ICSI is only recommended when you have associated male factor along with endometriosis, and that's a good practice point. And when you come for frozen embryo cycles, you find that the protocols, we can use a GnRH agonist co-treatment, and co-treatment for artificial frozen cycles have proven to produce an improved pregnancy rate. So you have the hormonal therapy for frozen embryo cycles, and along with that, we give agonist as a depot preparation sometimes to prevent ovulation to occur and fluctuations of the LH. But you find in this group of patients, agonist treatment has given a better pregnancy rate. So frozen embryo cycles, you can use natural cycle. So that is the upcoming cycle or a modified cycle. Modified cycle means you can start give letrozole and see the follicular development and add on with the trigger and support the luteal phase. And so insufficient evidence to support routinely, you don't have to use letrozole or atosiban. And you can either go for a natural cycle or go for a HRT cycle in this group of patients going for frozen embryo cycle. And whenever you go for a pickup, there is no need to freeze the embryos altogether and go for a transfer late. And that is a good point in patients with endometriosis. And luteal phase support you usually give in this group of patients, especially with endometriosis, because the biopsies and the progesterone level estimation has proven that luteal phase defect is associated in the patients with endometriosis. So both for ovulation induction or a UI or for ART, luteal phase support has to be given. Now my focus goes into endometrioma and surgery and what are the ART outcomes. And when you look at the birth rate between ART outcomes between surgery versus no surgery or medical line of management, not much significant difference, 23.7 versus 26.1 according to this author 2021. And as I told earlier, effects of endometrioma surgery on ART, whether you have to do an endometrioma surgery prior to IVF, a systemic review concluded that ovarian cystectomy for endometrioma prior to ART does not improve the live birth rate compared to no surgical intervention. So there is no much, according to Dunselman and Hamdan in 2015, there is not much difference between going for ovarian cystectomy prior to ART. Doesn't make much a difference. Quite to the contrary, you find there is a lowering of the AMH values. 10 studies showed that no significant benefit of endometrioma surgery on pregnancy or live birth rate compared to the expectant line of management. And you find there was no difference in the number of oocytes retrieved, embryo created, and the dose of gonadotrophins used. And coming to severe degree of endometriosis, now the decision comes whether you have to go for an IVF or whether to go for surgery. Here you find a picture where the advanced stage of endometriosis, both fimbria or the tubes appear to be adherent to the ovary and stuck behind the uterus, sometimes called as a frozen pelvis. But most of the times, 99% of the cases, you find the fimbriae is free and they are involved in the adhesions and forms this type of hydrosalpinx. So you find the damage to the ovary. The surgical indication depends upon the surgeon's skill. The costs are involved. Surgery definitely is going to reduce. Overall, you find endometriosis per se has reduced the AMH. Surgery is adding on fuel to the fire. And you find that the impact of the ovarian reserve may lead to premature ovarian failure. So on the other side, you find if you don't do surgery, you have the progression of the disease, there is increased inflammatory reaction, and whenever you do oocyte retrieval, you find that it's a difficult oocyte retrieval. You have to go transmyometrial, that is, you have to go through the uterus. Sometimes you puncture the vessels also. Sometimes you find the follicle doesn't grow at all. It results in cancellation of the cycle, contamination of the follicular fluid. Sometimes you puncture an endometrioma. It may result in peritonitis, and you find all sorts of problems associated with ART. And Leslie and co-workers, in women with endometrioma-related infertility, a dilemma they were facing was the right approach to achieve their dream, whether it is surgery or IVF. One cannot state the concerns regarding the potential toxicity of the endometrioma, because endometrioma contains iron and reactive oxygen species, and which may cause local inflammation, culminating in a burnout effect responsible for a diminished ovarian reserve. Despite misgivings, we find a lot of pressure is on the laparoscopic surgeon when he does laparoscopic surgery on a patient with a reduced ovarian reserve. Surgery does have a fundamental role to play. Surgery has got certain roles to play, and which are the patients will you choose for surgery, and which are the patients which you we send for IVF. So the benefit of surgery is pain relief. Patient is symptomatic, surgery would be better. And natural conception rates endorse this procedure. So patient is symptomatic, she has got pain and congestive dysmenorrhea, large endometriomas, more than 4 centimeters, surgery is going to be the best. And a large series of women undergoing operative laparoscopy for management of endometriomas, natural conception occurred in more than 50% after surgery. So surgery you have to select, not all patients you can select. Then I will come to the criteria which you can select the patients. 50% of the patients did conceive after endometriotic surgery for moderate and severe endometriosis. So consider surgery when the woman is in pain and interferes a daily course in her life. You find patient is having pain all throughout the day, congested day, dysmenorrhea, can't attend the office, can't go to the, can look after the children also and household chores, and you find a rapid increase in the size of endometrium. That is a possibility a malignancy can occur. And the third indication, suppose you're going for IVF, you find that the endometriomas are large, 5, 6, 7 centimeters. You can't go through the endometrioma and assess the follicles. In those cases, you may either deflate or produce a what you call drainage of the chocolate cyst, just ablate it and don't do a stripping and all if the ovarian reserve is less, and you can go for the retrieval later on. So there are recent European ESHRE guidelines and embryology guidelines. Operative laparoscopy may increase the chance for the natural pregnancy, according to Becker also, 50% chance of a natural pregnancy. And the broad consensus is endometrium is more than 4 centimeters. The clinical balance tips towards surgery. So any endometrium more than 3 to 4 centimeters, there is more goes in favor of surgery. And endometrium more than 4 centimeters interfere with the ovarian response. You find in this group of patients, the response to IVF, also the ovarian stimulation is also much less, and we may have to go for a laparoscopic surgery instead of going for an ART. So the factors that guide this decision would be the woman's age. When the woman's age is 37, 38, AMH is 0.8 or 0.9, you find it favors more of an IVF procedure. AMH is good, and you find the woman's age is less than 35 years, it points towards a surgical intervention. A previous history of surgery, think twice before you think about surgery. Only one surgery is allowed. More than one, think twice. There is no need for repeated surgery. Reserve is poor, definitely you have to go for IVF. And most important thing, a beginner cannot go for moderate and severe degree of endometriosis. The physician's expertise also you have to take into account. You can do a good surgery, or you can do a bad surgery and reduce the reserve, and she may not improve from her surgery, or she may not improve from an IVF procedure alone. So deep endometriosis, we heard a lot of deep endometriosis or deep infiltrating endometriosis is just challenging. Donors from Brussels concluded, yesterday we heard a lot of rectosigmoid resection. Donors concluded that rectal shaving should be considered as a primary surgical approach, and he reported 50% of the patients did conceive after surgery for deep endometriosis, that is rectal shaving, that is without resection of the rectosigmoid. Whereas another group feels that you have to resect the rectosigmoid for deep infiltrating endometriosis. And what about Castles in 2021? He revealed that systematic review meta-analysis, significant benefits of surgery for deep infiltrating endometriosis nodules before IVF. The live birth rate increased 2.22 times higher in patients with surgery when compared to the patients without previous surgery undergoing IVF. So definitely surgery has improved the live birth rate also in this group of patients with deep infiltrating endometriosis. So the absolute indications for surgery, maybe shaving, maybe sometimes you have to go for sigmoid, rectosigmoid resection, will be a painful nodule 3 centimeters or more. Involvement of the urethra occurs in more than 10% of the cases, and association of bladder endometriosis, bowel involvement when there is severe substenosis, definitely. Bowel involvement when you've done the MRI with contrast or you find the bowel involvement is, or a colonoscopy also, you find bowel involvement is an indication for surgery. And associated endometrioma, 3 to 4 centimeters is an indication for surgery according to the various guidelines. Now I just move on to Elgolix, which is a second generation GnRH agonist which has come into the market. And it is a GnRH antagonist which can be given orally. We have GnRH antagonist which can be given subcutaneously, but this is one of the treatments for improvement of the endometriosis associated dysmenorrhea, dyspareunia, non-menstrual pain, according to various studies, 2018, and a recent benefit, specific benefit effect of elagolix, a GnRH antagonist, has been cited as immediate pituitary suppression. You find whenever the pituitary is suppressed, you find that the estrogen level comes down and it doesn't have the initial flare-up effect of agonist, and you find the patient is relieved of the pain. So any patient coming with severe dysmenorrhea, with adenomyosis, with endometriosis, elagolix is a wonder drug which can be given for a short period of time, over a period of 3 months, but there are certain things you have to keep in consideration. The effect of elagolix, 200 milligram twice daily versus for 2 weeks, a trial is going on, undergoing those patients with endometriosis and adenomyosis. This drug is given 200 milligram twice daily for 2 weeks prior to IVF. This is known as the PROMISE trial. Sorry, not the PROMISE, the pregnant trial, fertility, sterility, December 2024, where GnRH antagonist is given, and this is on a multicentric, prospective, randomized, double-blind controlled trial for 8 weeks, and the results are awaited. May 2025, the results are supposed to be out. Then only we know that whether it is useful to give elagolix in this group of patients prior to IVF. This is the chart which you can, instead of giving injections, you can start with the stimulation and give elagolix, whether you can give 50 milligram daily or 200 milligram daily or 200 milligram twice daily. Only the trial will tell you which will be the ideal dose. So instead of injectables, it makes the injections to the patient more patient friendly, and supposed to reduce the OHS also by reducing the estrogen levels. So the question is, first line of surgery in deep infiltrating endometriosis or stage 3, stage 4 endometriosis. What is it? Is it first line surgery or is it ART? So these are the results from the literature, which I would conclude in the next 2 to 3 slides. It tells you systematic review, meta-analysis conclude that moderate and severe endometriosis associated with fewer oocytes, you find poor implantation, lower birth rate according to the earlier studies. Nowadays, it is not said it is poor implantation, only the oocyte quantity is less, but the implantation and the pregnancy rate are quite similar. So next 2 minutes, I'll be just taking to a couple of slides also. A large analysis, more than 347 patients undergoing ART database from the Canadian database showed that women with endometriosis have got the similar live birth rate. Only the oocytes are less. The quality and the live birth rate are not affected with endometriosis. This should be sternly told to the patients. And retrospective study, 16 years, 27,294 ART cycles, suggested that those patients with endometriosis have a low oocyte numbers, but pregnancy live birth rates are not affected by endometriosis. And the conclusion is, The live birth rate was 5.6 higher in the treated group when compared to the expectant management, and available evidence tells that both first-line surgery and ART can be effective, and deep infiltrating endometriosis with similar fertility outcomes. However, further analysis reveals that excluding studies involving endometriomas, you find the difference between surgery and ART should be considered in deep infiltrating and infertility. And the conclusion was both first-line surgery and ART can be effective in deep infiltrating with similar fertility outcomes. The choice between surgery and ART depends upon the patient's age, the severity of the symptoms, and the desire to have pregnancy and the individual risk factors. And you find that ART as well as laparoscopic surgery, you find ART cycles demonstrate the oocytes retrieved have similar potential, which is already told earlier. And finally, you find that management of DEA is a clinical challenge. It is multifactorial and aims to elevate pain, improve fertility, and enhance overall quality. Currently, you find the therapeutic options are primary surgical treatment and medical treatment using assisted reproductive techniques. So thank you very much for your patient hearing.
Thank you, Dr. Jayakrishnan. Knowledge shared is always a gift in itself. May I now invite Dr. Pratap Kumar to present a memento as a small gesture of our thanks to Dr. K Jayakrishnan.